evening, everyone. Welcome to Module 2, the most important module of the course. We are delighted to have an all-star crew. Myself, of course, Brett Christ and Matt Camuso are here. I'm going to moderate the session on avoiding pitfalls with femoral diaphyseal fractures. Thank you guys very much for coming. These are the disclosures for our speakers this evening. All disclosures and potential conflicts of interest were resolved prior to tonight's discussion. This is our agenda this evening. Similar to last week, if you were there, we're going to have a couple introductory slides, and then Matt Camuso is going to go over some cases. It's going to be quite interactive, and we encourage you to put questions in the Q&A box. He'll probably aggravate Brett and I with a lot of probing questions, so we'll hopefully have a nice discussion around his cases. And then Dr. Christ is going to discuss some post-traumatic correction of malunion, specifically rotation, and we'll have a good discussion around that. And finally, Matt will discuss one of the journal articles for tonight, and we'll finish up with a wrap-up. So at the end of tonight's session, you should be able to describe intraoperative techniques for getting alignment correct in all the components of alignment. And Matt, I think, is going to give an amazing a discussion about how to get all the components of alignment right, even in complex diaphyseal femur fractures. We'll go over how to perform a clinical exam for rotation, and we'll discuss techniques for radiographic rotational alignment measurements, both pre-op, intra-op, and post-op, and discuss an operative technique to correct malrotation. So I'll ask Mackenzie to maybe put up the questions. We're going to ask you 3 polling questions. Here's the first one. It's going to be good just to get an assessment and guide us with some of the discussions. Okay, so a lot of fracture table, but still a lot of flat top radiolucent tables. Okay, let's go to the next one. How frequently have you had to perform rotational osteotomies for malunion, specifically after diaphyseal femur fractures? Okay, that was a good question. Good question by me. Okay, third question, Mackenzie, please. Okay, thank you guys very much for your participation. So I'll just have one case that will go throughout the discussion tonight. So I'll just start with one of the cases of mine. Recently came to our hospital, a 32-year-old male with a closed proximal diaphyseal femur fracture. He's a software engineer.
So that's a juicy fracture. That one's totally straightforward. There's no way you can screw that up.
This one was, I had that attitude. I had a very arrogant attitude with this one, and it was a slam dunk for me. Okay, so what alignment parameters are difficult for you in this case, Matt? I would say none for you. So I thought length would be easy, right? It's a length stable fracture. Rotation, there's some geometric shapes there. I thought it was going to be quite easy. I know they talked about transverse being difficult, but I'm a good surgeon, so I thought that would key in nicely. It's ismic, so coronal angulation, sagittal angulation, those are going to be dealt with by just the IM nail. So surgery done by me, not by done someone else. Cortical read looked amazing. I did not perform any other check for rotation.
Why would you? It looks great.
So do you mean imaging wise, or you didn't examine him either?
I did not examine him
He
specifically
was too
for
busy giving
rotation.
people high fives.
We were giving people high fives. I thought the cortical read was very good. He was weight bearing as tolerated. He was doing well, but no specific exam by me to assess and even ask him about what he thought about rotation. And imaging wise, no, there's no CT post-op. So 8 weeks post-op, I specifically asked him, I said, tell me about how you're walking and how does your foot look? And he's like, yeah, my foot is externally rotated, but I thought that was from lack of physical therapy. And of course, most of the time in my experience, not. It's usually iatrogenic from a rotational malunion. And I can tell you, he was like so bothered by the fact that I malrotated his femur 20 degrees. So what could I have done better? This is a good introduction for my good friend, Dr. Camuso, who will go over with some cases, how to manage acute femoral diaphyseal fractures, how to get it right. He'll go over some cases that are seemingly simple to ones that are complex, but he's very good at just applying basic principles in a very sophisticated manner. Dr. Camuso.
Well, I'll first start by saying that you rarely get a.
And you guys, and by the way, you guys were very aggressive with me. I mean, with my intro slide, slam dunk. I mean, I was not expecting that. Okay, continue. Very aggressive.
I would agree. I think that you rarely get a guy who's as honest as Mitch is, right? So, can you see my screen here? Let's go back.
We're in presenter view.
I'm in presenter view, huh? That's no good. Let's stop that and go back.
You should make some boomer jokes, maybe.
Yeah, you should. Let's go back to Zoom and hit my.
There's a 50-50 shot. I'll do the same thing, Matt, so you're okay.
Desktop 2. I said desktop 2. Now let's see. Share. All right, do you see mountains?
Yeah.
Yes.
Okay, good. Okay, good. So let's go there now. So now do you see a slide?
Perfect.
Yes. Good job.
Okay, good. Beautiful. All right. So rarely does a surgeon as honest as Mitch show up and not blame it on physical therapy. I'm actually a big fan of blaming my malreductions on the physical therapist because well, why not? You know, it seems to go over better than if I tell them that it was me. Anyway, I'd like to tell you and talk a little bit about the importance of performing a really thorough evaluation and planning surgery for even the most simple of fractures. And I think that Mitchell's, and all kidding aside, his case, you know, really demonstrates that sort of thinking about and planning and doing these kinds of fractures, even if they seem very simple and straightforward, the same every time. We're going to show you some different ways to nail femurs, I think, just based on those polling questions. But we're not here to tell you that your way is wrong. Instead, what I hope you get from our next hour and a half is that you can use your own surgical experience to help optimize the way that you reduce these sometimes complex diaphyseal fractures, especially as it relates to rotation. I hope that you can avoid some of the common pitfalls that all of us have seen when treating diaphyseal femur fractures. And then remember that when we're through, those sort of final 4 assessments after femoral fracture fixation are key and critical to do before the case is over. So I'd like to start by presenting this case. This is a young man who is on a bicycle and struck by an automobile, and he's got a bit more complex fracture than one might see typically. It's a high energy injury that's comminuted. And the problem with it is that it just blasts away the diaphysis, right? So we love fixing fractures that happen at the diaphysis because the nail, as in Mitchell's case, you know, typically will do the reduction for us as long as we get the right starting point and the correct ending point. The nail will do the reduction for us. That probably isn't the case here. So here we got a fracture, otherwise healthy patient who's hemodynamically stable. Mitch what other information do you want with regards to this patient? And maybe more importantly, what challenges do you anticipate when you're treating this specific femur fracture?
So, you know, you made fun of me, but seriously, emotionally, I'm going to get geared up for this case, right? Because it's quite difficult, and I'm going to really outline. I'm going to come to the OR with a plan for translation, angulation, rotation, and length, because you really have no choice. So I think for me, that's the part of the femur. And then for me also, what I've learned is comminuted femur, femoral neck. Make sure there's no other femoral neck. And really, this is the one where you go back to basics again, examine the knee, and, you know, see how the patient is doing, and are they ready for the OR, and that whole, you know, business. Is it really isolated, etc.
Yeah, so I love that this one sort of increases your sphincter tone a bit more than your other one, right? Although
I don't know if I
maybe
use that word on a webinar here, but that's okay. That's fine.
Well, you thought enough about it that you got x-rays of the hip so that you showed that there was no femoral neck fracture, at least here. And I will tell you that on the CT scan of this patient, there was also not a femoral neck fracture present. So we've ruled that out, and now we can just focus on this difficult femoral diaphyseal fracture of the femur. So I think everyone does this a little bit differently. I think we all agree that the ideal management in this healthy young man is going to be an intramedullary device, but there's lots of things to think about. And so, Mackenzie, maybe you could bring up the first question. In preparation, which of the things is most important to you as you put together a plan? Because some of these things will direct what the other choices are, right? So perhaps the table may determine how you reduce the fracture, or what the entry portal is. But what is your priority? I want you to choose which is your priority and which drives the rest of the decisions. And maybe Brett, while you're considering that and they're answering, maybe you can tell us what is your most important driving point out of those choices? What drives how you manage this?
I think for that particular fracture, because the proximal segment is acting more like a subtroch, it would be positioning for me, because that would be something that would be a little bit not out of the ordinary, because I do a lot of lateral positioning nails for proximal femur fractures. But like, I have the standard kind of thing I do for reduction that I already have in mind, but for me, it'd be positioning for this one.
Okay. Okay, Mitchell, how about you?
A reduction would be important for me. I mean, the positioning for me really doesn't change. It's always supine. I always do a Piriformis Entry, just because the proximal segment, I'll be able to sort of negate that from the alignment as it's collinear with the canal. So that would be for me, reduction.
So for me, I sort of agree with both of you. I think both are critically important. I think, Brett, for you alluded to the fact that the position was important so that you could get the reduction properly. And so for me, reduction really drives all of the rest of it. So how I'm going to reduce it drives how I position the patient, what table I choose, what reduction aids I choose, and oftentimes what the entry portal and interlocks are. So as you said, Brett, if it's a real subtroch, if it's a proximal femur that's behaving like a real subtroch, I almost always position those patients laterally. And in many cases, we'll do an open reduction. In this one, I didn't think that this was going to behave very subtroch-ish. And so I felt comfortable managing it in the supine position. And so this is how we position the patient on a radiolucent table, an OSI table, which I understand now is familiar for only a third of the people that are participating. About 2/3 are doing a fracture table, which I think is totally reasonable. But I want to show you this other method and maybe sort of talk about some of the advantages of this positioning over a fracture table position. This is sort of what it looks like for me. They're in a bit of a scissors position. It's hard to tell here, but their buttock is a little bit off the edge of the table, while their chest and their lower extremities are on the table. So it's as if they're lying lateral with their buttock up to the side, but still supine. So their buttock is hanging out to the side a little bit better, presenting that starting point for the proximal femoral entry, whether it be piriformis or trochanteric entry. The leg is also on a wedge pillow, so it elevates it up to some degree, which helps with reduction, but more importantly, removes the lower extremity in the lateral beam of the fluoroscopic view, so that you're not looking at two femurs superimposed. By putting it on a bump, now we look at just one femur in and of itself. So maybe Brett, you, I think, do it this way as well. What are some other advantages to doing a free-legged nailing on an OSI table, do you find, over doing it on a fracture table?
I think you're able to move the distal segment in all directions. And so one of the limiting factors, like there are definitely advantages to a fracture table, but one of the limiting factors is that you can only move the leg in as much as the table allows you. So you can get sag, you know, you can use different things to try to push up the sagging segment. And I think it just allows you to not only move or position the leg where you want it, but it also allows you to get a better idea clinically as far as what the alignment is. I'm not saying that it's always easy with the patient, like in an oblique position or even more lateral than this, but it at least gives you a way to look at the entire limb in addition to be able to move it however you need to.
Yeah, I would agree. I like actually having the lower extremity free to be able to perform that reduction that I need. If I get sag here, I put a bump underneath the area that's sagging. I can use other reduction instruments, you know, in a very easy way to sort of drive the distal segment with respect to the proximal segment. If I'm having trouble getting my starting point, I just adduct the leg further, and then I can get the starting point and then proceed with my nailing, moving the rest of the limb around to adjust the reduction as I go. And so I actually prefer this method. I have someone that stands at the end of the bed and can drive the leg around, but many people will actually also put in a traction pin and put sterile rope off the end of the bed and hang a little bit of traction that will function as a sort of like a fracture table, but also gives you the advantage of having the ability to remove it and adjust the position of the leg and then reapply it once again. So I just want to bring your attention to one of the things that's challenging about this position is getting the lateral view of the proximal segment. So when you go into the perfect lateral view, a flat lateral of the C-arm, you'll see a very good lateral of the distal femur. But as you travel north to look at the hip and the starting point of your femur, the other hip gets in the way. And so there's different ways to overcome that. Many people will put a large bump underneath the buttock and the chest, and that obligately rolls in the patient. And I would say that's probably at least one of the pitfalls that can cause some rotational deformities in our patient population. So imagine if you roll the patient inwards significantly, and the leg continues to stay straight up and down, you've essentially created an external rotation deformity of that limb. And that's an unintended consequence. That's just you trying to get a better image of the proximal femur. And you don't actually need to do that. You can just get a better lateral of the proximal femur by rotating the C-arm, as you see in this image. Actually, we've canted up the C-arm significantly here to get an image that we need to see as a lateral of the proximal femur without bumping the patient up significantly. And by doing that, I have a less of a chance of creating this external rotation deformity that can come with free-legged nailing.
Just a comment, Matt, because I've had that issue a lot where, you know, inadvertently you're trying to get the perfect lateral distally, so you're externally rotating and causing that deformity. I was not my idea. I forget who wrote it up, but putting a handle on the bump out of tape, and after the nail is in, I have the nurse pull out the bump, but it's not irritating for them. Number one, I tell them before, so they're prepared. Number two, there's a handle, so they don't have to crawl under. There's a handle that pulls out, so that's just a trick. If you bump it up too much and you're having an issue, you can just pop that bump out.
Yeah, I think once the nail is in, then it's easy. You don't need it anymore. And so the starting point's been effectively established. The nail's in, so you don't really need it anymore. I love that trick. In fact, I'm going to use that, using a handle to be able to take it off. So they don't have to go underneath the drapes to get it out for you, because they're obviously very annoyed by that. They wouldn't do it for me. You must be a nice surgeon. You're nice to them. They wouldn't do it for me.
I'm also Canadian here. We're civilized.
That's true. In Canada, they do that sort of thing. So here we are in the operating room. We've got images, AP images of the hip and the diaphysis and the distal femur. Mitch, how are you going to judge this reduction? How are you going to judge length? How are you going to plan to judge alignment? And maybe as importantly, how are you going to plan to judge rotation? Will the nail do this for us? Will the fracture table, solve this for us? What is it that you need to do to plan and prepare for this?
I was taught entry point and trajectory. Entry point and trajectory. So just like doing a total knee with an intramedullary referencing guide, the anatomic axis or the medullary canal pops out collinear with the medial tibial spine. So if I put you, Matt, inside the femur, if I pushed you inside the femoral diaphysis and I had you come out at the knee, you'd come out at the level of the medial tibial spine or the PCL insertion. So piriformis entry, I need to exit collinear with the medial tibial spine with, like an 82-degree angle. And I have the x-ray techs measure that. So I'm just hyper-focused on that. Length I do from the other side with a radiographic ruler. Rotation, I do the lesser profile off a perfect lateral.
Okay, so I do something similar. I start by just getting the proper images of the contralateral side. And I do this in every patient, not just in the ones that are commoner. I do them in the ones that are simple. And my nurses and my PAs and my techs are all annoyed by it, but I haven't really been disappointed by doing that. So here's an image on the left of us obtaining an x-ray showing length, where it is centered on the femoral head and neck. And I've got a radio opaque ruler that tells us where the distal femur ends. As importantly, we've got a perfect lateral of the same femur that you see by perfect overlapping of the femoral condyle seen on the lateral view. And that is with the C-arm set at 90 degrees, perfectly flat trajectory of the C-arm. We then keep that rotation of the limb with perfect overlapping condyles and then rotate the C-arm up to perfectly vertical, so 0 degrees, and then slide up and take an AP of the hip, centered on the hip, centered on the lesser trochanter. And what I'm looking at there is that lesser trochanteric profile. And I save that on the C-arm screen because I'm going to use that later to compare the rotation of my injured side as I start to interlock the nail. So I'm going to move.
If you're really obnoxious, you can flip it left, right, so it actually appears as the injured side.
So
and you
it
can
looks
be
like a right.
critical.
Yeah, good idea. I like that too. So we'll move through this a little bit. I like Mitch, like to use the piriformis entry because, as you described, if you continue down through the distal femoral condyle, you hit the medial tibial spine. If you go retrograde up the femoral canal, you always exit in the piriformis. And so this is the perfect collinear starting point and entry point, and works well for me. Every time I know where it is. It's a perfect spot, and I never can get it wrong. So I use a piriformis entry for these, and this is us, of course, acquiring that. And to obtain the reduction and alignment across this very vast spanning comminution, I don't find all the time that just simple traction will do it for me, which is why I don't favor the fracture table. Because I still will get abduction, adduction, flexion, extension, malalignment. And so if I can't do it with gentle traction from my assistant, I don't think that I would be able to get it with a fracture table. I just move quickly to using shank spins. And you can see those shank spins placed here. It may also be a spike pusher. It could be a hook. Whatever it is, it's going to be something in one, or in this case, both segments to help line up each of the segments to bypass that zone of comminution and to allow us to pass our guide rod. Now I look critically in the segment of the bone that doesn't have an isthmus. And so in this case, I would argue that the proximal segment still sort of has an isthmus, but distally, it's become wider than what my nail is going to be able to come in contact with. And so when I look at my guide rod there, the guide rod happens to be somewhat medial in its trajectory. And so I worry that if I put my nail in that trajectory, that I'm going to end up in some varus. And so in this case, I place a blocking screw to make sure that that canal and that guide rod passes center, not just in the very distal femur, but also in the proximal part of the distal femoral segment, to be sure that that alignment is as collinear as I can make it. Perhaps a little bit subtle in this case, but I think that blocking screw preventing varus in this more patulous distal femoral segment will help maintain alignment in this patient that has a wider canal than the size nail that I can place. And so here we are measuring the femur, again, comparing it to those images that we saved previously. And I can confirm at this stage whether or not I've got the correct length or not. Pitfall number 2, however, is really easy and really simple to screw up. Brett, can you see the difference between these two images? There's an image on the left where the femoral head and neck is not centered on the beam, and the image on the right where it is centered on the beam.
Yes. Yep. I agree.
And so yeah, so those two images are the exact same images. The radiolucent or the radial-opaque ruler is in the exact same place, but you can see that it's about a centimeter different, right?
Yeah.
If the femur isn't centered on the femoral neck and head. And so if you're not centered on the neck and head, or wherever you centered the beam for your contralateral image, you can get up to 1 to 2 centimeters of difference, not even knowing it. And that's because of the parallax between the beam and the thickness of the patient's soft tissue envelope. So it's critical that you reproduce the image on your injured side that you had on the contralateral side. So if it's centered on the contralateral side, you've got to center it on the injured side. And that I personally have messed up and lengthened the patient by as much as a centimeter by just not centering my ruler on this proper part of the proximal femur when doing my measurements. And of course, it's true distally as well.
And also make sure that you have the tilt of the C-arm or fluoroscope in the same plane as the bone that you're imaging to, because that can also cause projection issues, like what you're talking about.
Yeah. So if you put them in a big bump, they're rotated up, and it's going to be closer to the beam, and so that may cause a difference in length measurements. So here we are, and we're about to lock the femur, and we call this the lesser trochanteric profile method of assuring the proper rotation. And so if I was fancy like Mitch, I would turn that image on the right-hand side and flip it over to be
it's
sure
not
that
fancy,
it
it's just logical, man.
But what you see here is we've compared two lesser trochanteric profiles by, again, doing the exact same method that I described earlier. So getting a perfect lateral of the distal femur with the leg in a secured position, and then rolling up 90 degrees from that, and then imaging the proximal femur, centering it, and making sure that that lesser trochanteric profile is symmetric. Brett, what are the final things that you do when you're done nailing a femur? Is there a series of things that you check to be sure you have your resonance checked to be sure that there's not anything else that needs to happen?
Definitely check alignment. I like to get an axial lateral view of the femoral neck. I feel like I can judge rotation better in that plane. You want to make sure if you're not doing, or even if you are doing reconstruction style screws, that you're making sure there's not a femoral neck fracture that's shown up. You want to make sure that you do a ligamentous knee exam. You do a rotational exam once the patient's supine. And then check for neurovascular damage, like make sure their pulses are symmetric, capillary fill symmetric.
Yeah, great. So I just call that the sort of final 4 checklist. So length, alignment, rotation. Mitch, are there any specific things that you check for? So we did length and we did rotation. What about alignment? Is there anything special that you check for alignment? You talked about the 82-degree angle to distal femur. What other things are you checking? Do you do you do a plumb line through the center head of the neck and the ankle? Do you get a flat top AP X-ray of the femur? What's your alignment choice?
If the nail, we're doing antegrade nail, diaphyseal fracture. If the nail target looks funny in the distal segment, so if it's either too lateral or too medial, and like you said, it's riding along one of the cortices, then either I'll put a screw in that case to occupy the space, re-ream, re-nail, or just for education and to make sure I really understand, I'll take a flat plate. Yes, a sterile X-ray. It's not a whole femur X-ray. It's an X-ray of the distal femur, the beam centered at the knee, and then I'll measure the angle between a tangent across the distal femur and up the axis of the nail, because the nail will be a surrogate for the anatomic axis of the femur. And, it's supposed to be about 81, 82, 83. And if it's grossly abnormal, then I'll pick a strategy to block the path of the nail and realign it. But I like to do that sterile. You're in the OR, you're not like emotionally done the case yet, and you're still, ready to adjust it. Or even before the interlocks go in. I have a case where the nail went down the wrong path, took the plain film, and then just took back the nail out and realigned it.
We all have sort of protocols for making sure that there's a femoral neck, that there's not a femoral neck fracture, and confirming the absence of that should be based on whatever your center's protocol is, whether it's plain films at the end of the case, or fluoroscopic views, or a combination of the above, or a postoperative CT scan, whatever it is. Making sure that there's not a femoral neck fracture is key. Examining the knee afterwards will avoid missing ligamentous injuries. And certainly if you've been on a fracture table, and we see this still in our center for folks that use it, you can give people perineal nerve palsies when they get pulled on for a while. And just as Brett said, checking the neurovascular status of the limb is key. I like examining and using the lesser trochanteric profile to judge the rotation, but I don't know that it's as accurate as I want it to be. And we're going to go over paper later to talk about its accuracy, but I confirm it at the end of the case as well. And look at how their legs lay on the table. I examine the injured limb and compare it with the contralateral limb to make sure that their rotation is somewhat symmetric. And so that to me makes for a successful case that can be complex to start with, but again, thinking about it and planning for all of the pitfalls that this case has for you, I think can guarantee a quite a good result in most cases. So I've got a couple other cases to do, but I've been going here for 25 minutes. And so if there are any questions, now's probably a good time to go to that. I can stop sharing, Mitch, and you can take over, and then we can answer any of the questions based on that case.
Okay, that was very good. That was very good. So one question, Matt, is a lot of people do troch entry nails, especially if the troch entry nail has a reconstruction option. So question for me, do you make the distinction between a quote geriatric nail and a reconstruction nail? Is there really a difference? And if you needed reconstruction option, whether it's 2 screws or some sort of screw helical blade type device, is it a big deal to use that? And how would you get the alignment right with a troch entry device?
Yeah, so I tend not to use a troch entry device when I don't have a geriatric fracture pattern, like a peritrochanteric fracture. I like to use the Piriformis Entry for a series of reasons that I started to describe, but maybe wasn't as accurate in doing so. The Piriformis is a known collinear axis for me. The reconstruction options in a Piriformis nail for me are 2 screws, which I think are better than 1 screw. They're also fixed. They're not dynamic. They're not meant to slide at all, like the geriatric nails are. And so For me, I choose, when I'm using a reconstruction type nail, a Piriformis Entry that has 2 interlocking bolts, in preference to the geriatric type nail, to avoid the malreductions that I think sometimes occur with a Piriformis Entry. And also because I don't need the big hole in the trochanter. I don't need the large single screw fixing the proximal femoral segment, and I feel like I have better fixation with 2 separate interlocking bolts like you do in a reconstruction nail.
So I assume, you know, like in my center, level 1 trauma center, we didn't have a reconstruction nail for a while. So we only had a quote geriatric nail. So I think a lot of people don't have access, maybe they do, may not have access to any nail, you know, reconstruction or not. They may just be able to use a geriatric long nail. For that
I think
case.
it's okay, and I don't think it's, you know, if that's what you have, then that's what you have. I think it becomes harder as the fracture becomes maybe a bit more subtrochanteric, because it really depends on your starting point and the anatomy of the proximal femoral nail, and whether or not your starting point matches up with that proximal femoral nail, because we see commonly fractures that get reduced in varus, especially as they become closer to the lesser trochanter, as we use those trochanteric entry nails with more lateral starting points. We see that commonly, but we don't see it with Piriformis Entry nails really ever. And so for me, I'm just more comfortable doing that. I'm confident getting that starting point, and so it's not a difficult starting point for me. I think a lot of people, a lot of reasons that you see those nails in centers is because it is easier, especially in the larger patients and in patients that are being positioned on a fracture table, to start the nail on the trochanter, right? I mean, it's just an easier place to access. And so there's no question that there's some easier parts to using that device.
Okay, very nice. Let's, we're gonna move along here. Very good questions, guys. We encourage more, so we're not all yelling at each other up here. Okay, so how do I fix this? So this is back to my case of my patient that I caused a malrotation. So how do I fix this accurately, and how do I diagnose this? So prone physical exam. So this is me in the operating room. This is the leg that I malrotated. This is him prone. So this is the amount of external rotation he's already hitting, and potentially has a little bit more of external rotation because his leg is the blocking. Here's the normal side. He has a fair bit of external, but clearly it's asymmetric. So he really was bothered by it. So I said, let's get a CT scan to actually quantify this clinical exam. So I think Brett's going to go over this a little bit, so I'm not going to really spend too much time on it, but this is a CT rotational profile where we put an angle, a cob angle along the femoral neck and a horizontal on the right. So it's pretty flat. He's at 1.83. On the left, he's at 3.85. This doesn't tell you anything, of course. This tells you nothing until you do the math and add up the femoral condyles. So you can see this femoral condyle is internally rotated, which means he has some anteversion, and this one is externally rotated, where he has some retroversion or retrotorsion, as Dr. Christ will call it. So we're going to turn it over to Brett, who's going to go over a case of how to fix post-traumatic femoral malrotation, which I think is really, really, really good to know how to do and learn how to diagnose, because I can tell you we're causing a lot of malrotation, and I think it's symptomatic. I'll just say that.
All right. So nobody can see the presenter view, right?
You're great.
That's great, Brett.
All right. Thanks. This is, it's been great being a part of these. I really enjoyed the interaction in the first section. We've kind of gone over the learning objectives, so we'll jump into this case. So this is a 26-year-old male who jumped off of a bench and sustained this proximal third femoral shaft fracture. He was placed in a hair traction splint and started having symptoms of it when he got to the ER, and he had no other injuries. So he's relatively healthy. He works out a lot. He's kind of the prototypical healthy patient that you want to take care of. So these are some kind of the series of images that you have for AP and lateral views. You can see the traction splints in on that lateral x-ray, and we try to get, usually most adults don't get placed in this, but we usually try to get them out of it as soon as you can, because you can cause a lot of skin problems if you leave them on for, you know, more than about half hour to 45 minutes and cause sciatic nerve injuries, etc. And so this is the image on the right is after he was placed in 15 pounds of proximal tibial traction. And so what's the plan? This again seems like a pretty straightforward femur fracture, similar to the one that Mitch showed initially. And so what thoughts do you have? This came in on a Saturday. One of my partners is on call. And are you going to get advanced imaging? He didn't have any other issues. It wasn't high energy. It was just off of a bench. Are you going to do a straight plan for a straightforward Piriformis Entry antegrade nail, a greater trochanteric antegrade nail, or retrograde femoral nail? So we'll have you vote on that. All right, so over 50% are doing a Piriformis Entry, and that's higher than I thought it might be. The retrograde femoral nail is definitely still an option with this level, and some people would even push it to those that are closer to the lesser trochanter. So all good options, and not a bad idea to get advanced imaging like a CT scan if you're worried about a femoral neck fracture or involvement. Okay, so the call team goes for a greater trochanteric antegrade femoral nail. So these are intraoperative images that you can see here, 2 locking bolts above and below. This actually ended up with an open reduction. They weren't happy with closed reduction. And so this is after the locking bolts are in distally. It's not a perfect lateral of the knee, but it is a perfect lateral of the locking bolt, so showing that they are actually going through the nail. This is just marching up the femur with x-rays at the fracture site. It's of interest. You can see that the cortical diameters aren't symmetric. And this is the proximal view here. And so how about the fracture reduction and rotation alignment based on these images? So if you take them all together, we don't have other like contralateral images like Matt had, but these are the images that you have at the end of the case. And so here's another polling question. So do you think there's normal anti-torsion? So, and the difference between torsion and version is version happens above the lesser trochanter. Torsion is how the bone changes from top to bottom. So do they have normal anti-torsion 10 to 20 degrees, decreased anti-torsion 0 to 10, or real retrotorsion of less than 0 degrees? All right, the important thing is that everybody kind of noticed that, or at least 60% and 78% noticed that, you know, there's something abnormal. And so if you look I thought they had actual retrotorsion. So even with the femur externally rotated, and you can see that in the distal segment, the axis of the femoral neck is posterior to the anatomical axis of the femur. So in my mind, that means that they are in retrotorsion. And so the knee is stable, leg lengths are symmetric, like lengthwise, the fracture lines up well, even though it had that medial butterfly, you had a good cortical contact laterally. No hip motion exam documented. So they're in the same boat as Mitch after the high fives. And then weight bearing is tolerated. So are you happy? Mitch, Matt, are you guys
Very
happy? Yeah, you guys feel like, if you recognize this, Like, what would you do? Are you like, well, he's, you know, maybe that's how he was, or, you know, let's see how he does with it. What are your thoughts?
I mean, if I'm not happy, or I suspect that there's a rotational deformity, I'll typically, you know, like in this case, I might just do a lesser stroke profile from the other side. But if I'm out of the OR, I'll quantify it with a CT scan, speak to the patient, and at least determine it. But again, like my mistake in my case was I was overconfident, and I didn't even think about it, and I didn't look out for it. And you know, if you're doing an open reduction, you know, your brain potentially won't let you think that there could be an issue.
I think, you know, having the butterfly fragment did potentially make it a little bit more challenging from an open reduction standpoint. But, you know, I think they manipulated the bone fragments to be able to get the guide rod across. It wasn't, you know, clamping it or anything like that. So, Matt, what are your thoughts? What would you do at this point?
So I think it's really important to engage the patient, right? So it matters what they're experiencing. I mean, we're doing this fireside because we've recognized that getting rotation right is difficult. And even the things that we're talking about, the lesser trochanteric profile, the physical examination, the other things, the cortical step off, none of those things are very sensitive or specific. And so we can't hang our hat on any of those things. And we'll learn later in the paper that we're going to show that they're good, but they're not great. And so we can be wrong, even if it looks right on the radiograph. So for me, I think it's really important to engage the patient and say, look, I know I got your length right because I know that the two ends are touching each other. I know the alignment's right because of it's a diaphyseal fracture, but the hardest thing for us as surgeons to judge is the rotation and is it correct? And so I think it's correct, but I really want you over the next 2 weeks to feel your leg as you move around. And if you feel like it is malrotated, tell me now. Tell me now. Tell me in the first 2 weeks, because it's easy to fix in the first 2 weeks.
Yeah.
I can fix it by just popping your bolt out, rotating it, and putting a new one in. Because if you tell me it's not right, I'm going to get a CT scan and document it. But if they don't, then I'm okay with that. But if they feel like it's not right, then I'm going to investigate it with a CT scan, quantify what it is, talk with them about how much we think is acceptable and how much isn't, and then make an intervention if we think it's warranted.
I think those are great points. And so, like I said, I'm concerned about retrotorsion. So yeah, you see the cortical step off there indicating that the reduction isn't at least rotationally right. I think like lengthwise good, et cetera, translation pretty good.
Can I just make one more point that was really, you know, my patient who is an engineer, very intelligent, this may be obvious to all of us, but he didn't
Engineers
think,
are the worst, by the way. Engineers are the worst. They're going to like obsess about the 2 degrees.
But he didn't think that I malrotated his femur. He was totally into physio. He's like a fit guy. And I, like you said, man, I asked him, and it's so amazing. You asked them, I said, tell me about your foot. Like, does it look? And he's like, no, my foot's like horrible. Like it's rotated like 30, he looks down, he's looking at his foot. He's like, it's totally rotated out. And I'm like, well, I screwed it up. And then he starts to realize that could happen. So they don't know that, I guess, that could happen. So I think asking them is very helpful. It's a very efficient way to know if it's malrotated.
So he actually post-op day 1 went back to the OR for fasciotomies because he has become kind of has an issue with pain. But there was definite concern for fasciotomies or compartment syndrome. So he had dysesthesias in his foot. He ended up getting anterior, posterior, medial fasciotomies, and went back a few days later and had it closed. There was no muscle necrosis. He followed up with my partner 6 weeks later, complains of right groin pain. And he's still tentative palpation over his fracture site. And so these are his plain radiographs. The plan was to start physical therapy, and if he still was complaining of pain at the next visit, the plan was to get an MRI to evaluate for intra-articular hip pathology. And you can see here with how they did the image, it actually makes it look like he does have anti-torsion. But look at the knee rotation is not right to compare that. So 10 weeks out, comes back, right groin pain, not better with physical therapy. He's starting to get some callus to form at his fracture site, at least laterally. No change in his hardware or anything. He has pain with groin pain with external rotation, and he gets an MRI and is referred to me. Still using assistive devices, very aware of pain at his fracture site and in his groin. It radiates to his medial thigh, but not past his knee. Worse with sitting and hip flexion activities. No regular medications, using a crutch. And he was able to ride a stationary bike for 40 minutes though. So this is I tried to get one image that would be the best one to show his, if he had a labral tear. This is the sagittal T2 image. His cartilage looks perfect, no labral tear. Here's the axial oblique. That's the one that's going to be usually most sensitive for labral tear, no labral tear. On exam, so these are his patient-reported outcomes that he has. So his hip is bothering him. He's complaining at 8 out of 10 pain. He has a lot of provocative signs for hip issues. And I can't do a supine range of motion exam because of the amount of pain. Prone, he could externally rotate 31 degrees on the right, 0 degrees of internal rotation. Left side, 61 degrees of external, 15.6, and it was limited by his right hip pain. Like I couldn't move his left hip more because his right hip started to hurt. His anterior hip structures were tight with bilateral rectus tests, and he was limping basically on the right side. So this is a great shout out to the osteotomy and deformity non-union course that we did last summer. This is Mitch showing how to do a prone hip exam. These are available on the YouTube AO North America Trauma YouTube channel. You can see the whole course. So he had a negative straight leg raise for spine issues, knee had good range of motion, and he had no neurovascular issues then, like his dysesthesias would come and go in his foot. So he had right groin pain after an IM nail, and is it coming from his hip? He does have abnormal range of motion, so I was concerned for femoral retrotorsion with the decreased internal rotation. So they're going to walk like a penguin. So if he wasn't having so much pain, he'd walk like a penguin. And so that's why you need to ask.
It's as if he has a skippy, right? He walks like someone that has a slipped capital femoral epiphysis.
Yeah, so you ask them how they walk beforehand, because people do externally rotate their hip to help with pain. And then you can also make sure they sit and have their knee flexed to make sure it's not coming from their tibia too. So if their knees or if their foot still turns out with their knee flexed, then you're going to have some tibial torsion issue as well, or something coming from below the femur. So I get a CT scan. He has a mild amount of acetabular retroversion. Sorry, Mitch. Femoral torsion. This is a great paper comparing 3 methods, and this is the most reliable method where it's hard to do it on just one cut, but you basically try to superimpose where the femoral head is, where you're between the greater and lesser trochanter. And this paper kind of has the references to all 3 that they used. It's a good paper to look at. And he had negative 6 degrees of retrotorsion. So just like Mitch showed, and here's a picture of Mitch again with the CT evaluation showing the differences. So if they're pointed in the same direction, you subtract the larger from the lesser. If they're in the opposite direction, you add them together. So he had basically negative 6 degrees of retrotorsion, and normal kind of plus or minus is 15 degrees of antitorsion. So this is what his 3D rendering looked like. So his problem list is right groin pain, femur fracture not healed, 6 degrees of retrotorsion. So he is set up for femoral acetabular impingement with his acetabulum as well. So my plan was to do a rotational femoral osteotomy. And I like to do all rotational osteotomies in a lateral position because one of the questions that was asked was, what about the greater trochanter profile or overlap with the femoral head technique that was done in cadavers? I really don't like just depending on AP imaging. I think it's too, even lateral imaging can be hard to see, but I think AP for me personally is more challenging. So I depend on the lateral imaging a lot. And so put him lateral on a beanbag, radiolucent flat top, took the screws out, and then got his lateral of the knee and lateral of the hip. So basically, like, we're at best within about 5 degrees. Like, I'm trying to go between 5-degree intervals is what I'm trying to go through. And Ken Koval, I think it was Ken Koval in the early 2000s, published how bad we are at rotation for femurs. Like, if we get within 15 degrees, like, we should give a high five, but I think we can do better. And so this is -15. So I thought he was between those two, even though for that positioning. So I decided to do an osteotomy below his fracture site because I thought the butterfly was partially healed and it would screw up my rotation. So did 2 terminally threaded 2.5 millimeter shank screws into the femur with the proximal one kind of true lateral. The distal one is going to be my amount of correction that I want. So I'm internally rotating the distal segment to increase anti-torsion. So it's going to be angled 25 degrees posterior to the reference wire. And then the osteotomy was pre-drilled with drill bit, like 6 different holes or how many you can get. And then low energy fancy osteotomes that I got from Mitch that helps cut and then rotate so you can crack it. And so this is what he looked like with correction. So at the end, your pins should line up. So the distal segment was internally rotated 25 degrees. I use a padded Mayo stand to help hold the distal segment in that position so I don't have to depend on somebody moving things around, and kind of just perseverate on those pin positions. And so this is with the guide rod in place. So this is at 15 degrees of anti-torsion and 20 degrees of anti-torsion. So I think I got him between 15 and 20. And with his acetabular retroversion, I'm okay with him being more than 15. And so this was a question that one of the participants asked, like, can you use the nail as a guide for torsion? You can, because most of the recon nails, this has a 14-degree anti-torsion, but sometimes it's hard to get that screw right down the center of the neck. And so I don't just depend on it. But you can see that to get the screws in distally, the nail is a little externally rotated. So the nail or the screws proximally are not going to be in the center. So that's at 15 degrees of anti-torsion. That's at 20 degrees of anti-torsion, and the nail has 14 degrees. And so I'm still not just depending on the nail, but you can use it as a cue. So, or a clue. And so I did use fancy staple to compress the osteotomy as well. And so preoperatively 6 degrees of retrotorsion, postoperatively, again, it's hard for the x-ray tech to get that perfect lateral of the knee distally. But there, it was closer than it was, but I thought that we did actually do what we saw fluoroscopically. So 6 weeks, his groin pain's gone. He's still using a crutch. His Hoos Jr. score is improving, and his right hip exam supine this time was 20 degrees of internal rotation, 30 degrees of external without pain, and it actually matched his other side. And so the take homes are perform clinical exam for rotational alignment, watch their gait, do it prone if you can. It's hard to do that intraoperatively, like Matt said. I guess you could flip them prone on their patient bed or something before they wake up, but the anesthesiologist should probably hate you for that. As far as looking at rotational alignment, I really prefer the lateral x-rays. I think my eye sees it better, and I'm still not perfect for sure. CT scan is the best. So I haven't done any of the intraoperative 2D, 3D fluoro that gives you a CT scan equivalent, but that would mean 2 spins, just remember. So 1 at the hip and 1 at the knee. And use intraoperative techniques to correct malrotation. Use your rotational references and get your fluoro techniques. And so with that, I'll stop sharing and take any questions. or banter from the faculty.
Brett, I have a question. I'm interested to hear that you prefer judging the version on the lateral view, because I find it, number one, hard to get that view because of the other limb. And then secondly, I find it hard to draw those lines that you drew. They look very subjective to me. Is there any tricks that you can give me to help me use that view in addition to the lesser trochanteric profile that I use?
Yeah, so the lines were just to make sure that the participants saw it. But basically, even if you're you're not going to take a goniometer and measure, like if you put reference wires in and stuff like that on an acute fracture, which you could do. And I will admit, I corrected somebody's natural retrotorsion to 15 degrees of antitorsion. So far he likes it, but we'll see how he likes it down the road.
I think that's okay. I think that's okay sometimes. Yeah.
Yeah, but I think so. It is totally dependent upon you getting the right setup with the patient. So I do the majority of my diaphyseal femur fractures like you do it, sloppy lateral, build up a bump for the buttock and chest, but basically they're kind of semi-lateral, and so that does help you be able to get the lateral of the proximal femur. Like, you just have to be careful, like you guys both mentioned. You don't want to rotate the distal segment to get the true lateral view of the knee and then screw up the rotation at the fracture site. And so I was going to mention, one of the things you can do is, if you're having a hard time, especially with a flat top, most of them do the bed rotates. And so as long as the patient's secured, you can actually have the bed rotate rather than rotate the limb. And I think that can be helpful in getting your imaging for both the evaluation and then also for putting your locking bolts in. But I think it may be just getting used to, just because like I do elective hip preservation stuff. So like I'm perseverating over it, and my eye just focuses on it. So I think if you really like start being able to reproducibly get that image, that true axial view, which you get for hip fractures all the time, just kind of make sure you're getting that true lateral of the knee. And then, whatever the difference in the C-arm is to make that lateral happen is your torsion. So.
There was a question, Brett, about can you use the Chance pins for measuring derotation with the nail in situ for an acute locking bolt revision? If not, how do you do this?
I think you can. You may have to use the not 5mm Chance pins. You could use the 2.5mm one. So I've actually done that, and even hooked up a distractor. You can do an X-fix. My partner, Mauricio Cafuri, does it a lot for his distal femur rotational osteotomies to do the correction and then maintain it while he fixes it. But basically, you have to be able to get a pin in. Usually you can do it on the lateral view, just at the level, just proximal to the lesser trochanter. And then you can do it basically at the epicondylar axis. And so it's a longer distance than like right at the fracture, but then you're able to do it. And it does depend on your naked eye. And then like there are apps you can use with smartphones where you can draw angles between the pins, and not only that's why I think it's easier to put the correction that you're wanting in the whichever segment you're rotating, and then making them parallel means that you got it right. So I prefer to put the deformity initially, and then so when they're parallel, that means the deformity is corrected. And we do have a sterile goniometer that we use to try to help get that right, but you can use smartphone apps you have to have somebody do it non-sterilely from the end of the table.
And then scrub out when someone calls you on FaceTime and screws up the whole thing. Yeah, that experience. All right, we're going to, I think Matt was talking. Matt, you're on mute. Not sure if
he's having audio issues. There was a question about lateral positioning. Oh, so yeah, you can. So that is one of the problems with lateral positioning, is that you can induce external rotation of the distal segment and cause valgus. So especially like distal third fractures, I don't do it for distal third fractures because you're more likely to have that happen. And then so I don't use like a commercial foam support. I think it potentially bumps it too much. So I use sterile bumps to do that. So basically, I use like the ASIS as just a general rotational thing with the patella clinically. And then I always get that doesn't tell you what the proximal segment is, but if it looks like you have an AP of the hip, I kind of try to look at the patella and the ASIS, and then also do the lateral axial views. And I will do the lesser profile sign as well to help with that. I just think for me, it's harder to do the lesser profile because it's very subtle sometimes.
Yeah, I think they're all subtle, to be honest. So let's move on. Thank you very, very much for that case. That was very, very good. So just to finish off with my case. So my problem is for my patient was status post left femur IM nail. He had callus, like you mentioned, Brett, with your case, that butterfly piece was healing. My patient had a lot of callus. So my patient's right side, he had 14.6 degrees of anti-torsion.
Yes.
And his left side was 4.9 degrees of retrotorsion. So to determine the magnitude of the deformity, I add those two numbers. So he basically had 19.5 degree deformity. What degree which way was it? It was externally rotated. That is, the distal segment was externally rotated by me. And I actually told him, I said, let's just, we're going to have to do an osteotomy anyway to fix it. Why don't we just see how it goes? And he called me after, and he couldn't live with it. So I did the same thing, Brett. I did an adjacent level osteotomy. I used smaller Shantzman, one in the lesser trochanter corridor behind the nail, and one in the distal femur around the nail. And I use a sterile goniometer typically, but occasionally I'll use that Carpenter app. I agree with you, Brett. I make them collinear at the end. So this is him with his wires collinear after. And he was quite happy. So I think we'll move on to the Journal Club article, if Matt Camuso's audio can be fixed. Matt, we can't hear you. No comment.
You log off and log back on.
One of the kids is using Netflix again.
Okay. Yeah. Any other questions? Feel free to ask us. We'll give Matt a minute to see if he can fix his audio, and we can go over that article. Brett, your case, the patient probably had. I mean, he didn't seem to have a lot of hip rotation. Like he didn't have a big arc of rotation. So he was probably very sensitive to malrotation, is what I suspect.
Yeah, I think supine. I thought it was pretty normal at the end, but I agree. Yeah, it was. People do get labral tears with traumatic events to the lower extremity for sure, especially femur and hip area fractures. But yeah, I think especially because he had acetabular retroversion, which wasn't horrible, but it was that just made him more likely to get hip pain when he's, like you said, sensitive to rotation as it is.
Matt talked about one of his learning objectives was preparing for the case, which we always talk about that. But do you what's your rhythm in the OR for these? Do you have physician assistants or minions that set up the patient, or are you setting up the patient? Because if you come in and the leg is draped, you're not doing a lesser troch profile the other side necessarily. What's your rhythm before?
Yeah, I think I always, it doesn't always happen. It ends up that they end up getting bumped before I do the physical exam, but I clinically examine the uninjured side and write it on the board. And then especially if it's comminuted, I'll definitely get the lesser profile sign. And I should be doing it more. I've just become so dependent on the true lateral views. And I feel like it's pretty reproducible for me, at least within 5 degrees, or at least if I'm going to be off, I'm going to be off in a more tolerated way, like anti-torsion. But I think it's important to definitely make sure, like if nobody's ever worked with me before, I'm definitely there during positioning. If they've worked with me and I feel like I know they're going to do a good job, I let them set them up. So our fellows have been viewing on these. So I guess if I let them set up the patient next time, they know I trust them.
They know you're loved. They're loved. So there was a very, very good question about, how embarrassed should you be if you do an open reduction? It wasn't the words, but like for me, an open diaphyseal fracture is my favorite fracture, because then people don't look at me and make fun of me for doing an open reduction. So I would agree with this person's question. If you are in any way concerned, seek out a open reduction. Doesn't mean you have to strip the bone. It's like, seek out the open reduction, get it reduced, and like, look at my case. My patient needed a return to the OR, an adjacent level osteotomy. So did yours. That is a lot more morbid than an open reduction. And there's literature to support a safe open reduction is good. What are your thoughts on that, Brad?
Oh, I will try closed reduction for maybe 15 minutes. And it's usually simple fractures where you get muscle trapped, and they're more difficult than the comminuted ones are more difficult for overall alignment, and particularly rotation, but like getting the coronal plane and sagittal plane, like I feel like you can do that pretty repeatedly with percutaneous reduction aids. But if it's a simple type fracture pattern, I'll try like 15 minutes before. I never bust out the F tool. I think that potentially does more soft tissue damage than a limited open reduction that's done well with limited stripping, like you said. I know plenty of people use the F tool and use it, not the F bomb, the F tool, use it routinely and have good luck with it. But I've just not had that experience, so I don't use it very often. But I would much rather go with the percutaneous reduction aid or a limited open reduction technique to get it right, like you said. You got a great point. Like you could potentially save them an extra surgery.
Matt, is it working?
Can you guys hear me?
Yeah.
Ooh, yeah.
Woohoo!
Oh man, I'm sorry.
You missed a great discussion, but anyway. So in the spirit of the fireside, we do want to go over a journal article, because I think it's important as we're all interested in best practice and patient care. So Matt's going to tie in some of this rotational stuff.
All right, guys, can you see this? This is
Perfect.
Yep.
I apologize for the technical difficulties. This is a paper that is done by a gentleman named Marshawn out of Utah, a bunch of really thoughtful, quality guys who studied this in a very sort of regimented way. So they understood the challenge that we all face with assessing femoral rotation, and realized that there are many different ways to do it, as you've seen this evening. And so what they set out to do is to judge which of the 3 most common methods is best: the true lateral technique, the horizontal technique, and the lesser trochanteric technique. And so what they did was they obtained cadaveric specimens, pairs, and kept a normal side, and then took the contralateral side for the same pair and osteotomized it, and then rotated that femur at different intervals internally at 0, 5, 15, and 20 degrees, and then externally at at 5, 10, 15, and 20 degrees, and got fluoroscopic images of both the normal and the abnormal side. And then what they did was actually engage surgeons, attendings, fellows, and residents via an online OTA survey to see who could identify those fractures that were malrotated, which direction they were malrotated, and then they also compared the individuals to see who was better at it. So this is one of the techniques, the true lateral technique. It was described by Tornetta in 1995. And what it does is it does exactly what we described, gets a perfect lateral of the distal femur, and then rolls up to the hip and gets a lateral at the 90 degrees, and then rolls up and gets a perfect lateral, which is what you see on the left-hand image, where the greater trochanter arc is perfectly centered over the arc of the femoral head. That's the true lateral image. And then that angle that you get with the C-arm is the version that then you try to correct and to make identical on the contralateral side. So again, this is probably the oldest technique that has been reported, and this is at least somewhat like what Brett will describe, the true lateral technique. This technique by Broughton was described in 2000. It's called the neck horizontal angle. It's a little bit difficult for me to understand well, but it's really quite similar. What it does is it assumes that the neck lateral is a perfect lateral with the floor. We call that the horizontal line, and then compares that to the neck version. And so this is another measurement that can be made routinely, comparing the horizontal line with the neck axis version. We call it the neck horizontal angle. And that was the second method that they used to try to determine rotational abnormalities. And then the last has been described by many groups, and Chris Craddock was probably one of the first, which describes the lesser trochanteric profile, which is what we've described already, which is the perfect lateral of the femur in a horizontal plane, and then rotated up 90 degrees, and then comparing side to side the lesser trochanteric profile. And you can see that it can be somewhat subtle. You know, this rotation here is probably on the order of 10 to 15 degrees difference, but it's quite subtle when you look at it side to side like that. And so what they did is they surveyed the OTA. They got about 85 surgeons to respond. Only about 80 responded to it completely. And they all said, or at least 80 out of the 85 said that they used some fluoroscopic technique in general to help judge reduction when they're nailing femurs on their own. When they then asked them to look at the images that they had saved, the different rotational images that they had saved using the 3 different techniques, they found that surgeons could correctly identify more than 15 degrees. That is, they could identify the 20-degree malrotation about 63% of the time. If you just took out the true lateral technique that Tornetta described, then actually if you threw that out, then it was even better. They could identify it correctly 67% of the time. So that's I suppose pretty good. This is what the actual results looked like. The lesser trochanteric profile clearly was better than the others, but they all to some degree were sort of a flip of the coin. The true lateral technique you could see here was a true flip of the coin. Neck horizontal ankle not a lot better, but the lesser trochanteric profile was the best of them all. What I thought was interesting was that it didn't matter who it was that was judging the malrotation. So residents and fellows and attendings all did equally well, or I guess you could say equally poorly, in identifying malrotations of the femur. And so which technique is best? Well, this paper would suggest that the lateral trochanteric profile method is the best, closely followed behind by the neck horizontal angle, which I think is what Brett is used to using. I think if you combine all 3, then maybe you are even better, but this paper would suggest that if you combine just lesser trochanteric profile with neck horizontal angle, that you'll be right 67% of the time. So So lots of information here, but what are the takeaways? The takeaways for me are that lateral trochanteric profile technique is reliable, and that it'll tell you when you're malrotated more than 15 degrees, which I think is sort of the cutoff for most people. More than 15 degrees in most people's minds is too much and would warrant some further evaluation and certainly intervention. It's reliable regardless of the level of training. But I guess for me, the most sort of concerning finding is that using any of these radiographic techniques, we're still wrong 1 out of 3 times. And so it speaks to the fact that we can't just hang our hat on one technique. We need to use other things like the physical examination, like CT scan if we're not sure, like the cortical thicknesses that aren't perfect, but will at least give us a little bit of a better understanding of whether or not we have malrotation. So if we look at just one factor, we're often not purely accurate. But if we add 3 or 4 factors together, we're going to get to more accuracy. And as I said, I think, in the end, the most important thing is what the patient feels and what they are experiencing. And if they experience the feeling that they're malrotated, then I think that warrants an investigation for sure.
Thank you, Matt, very much for that. I would, I would implore all of us to apply some of these techniques the next time you have a case, especially a monotrauma or an isolated closed femur fracture. I think it's a lot of it's a challenge, and it's very rewarding to get it done correctly, including rotation. Brett, any critiques about Matt's presentation style?
It's excellent. No one could do better than Matt. That was a great summary of the article and going through the techniques. I think, like anything, the more cues you use, the better you're going to be. So I think, like he said, adding multiple techniques is helpful. Using the built-in version or torsion of the nail. I find one of the things with that technique is that if you have a piriformis entry nail where you have to, if you basically have the nail go right down the neck where the screws are going to go, your start point's too anterior. So you're always, at least my experience is, my screws are always slightly aiming a little more anterior to make sure they're in the neck if you're doing a true piriformis entry. If you're doing a trochiformis type thing, then you can go mid-axial of the neck, and then that's different, or a troch entry nail. But I think you just have to have multiple checks, do it all, and then you are going to be less likely to have to, it's not fun to go tell a patient that just right after they get done with surgery, hey, we got to go back. So.
No, but at least you're aware of it.
But you should do it. I'm not saying don't do it. I'm saying it's not fun. So try to minimize those opportunities. And then if it's recognized, do something about it.
Yeah, I think just the awareness, of rotation, the hidden deformity is important. And I think patients are, they want to, one of my take-home messages, they want to get their bones put back together properly. Who are we to judge that it's good enough? They were in an unfortunate incident. All right, guys. Yeah.
Mitch, I have a 2-minute case that's just a compare and contrast that sort of illustrates what Brett was talking about. Do you mind if I share it?
Sure. Perfect. And then we'll wrap it up right after that.
Can you see it?
Yeah.
All right. So right side hard, left side, or I guess left side hard, right side easy, right? So this is what it looks like when we're through. And so which side is malrotated? It sure looks like, if any.
Right side looks bang on, Matt Camuso style.
Looks bang on, and left side doesn't, right? Because we're looking at cortical thicknesses. But the truth is that the right side was the one that was malrotated. So we just can't hang our hat on cortical thicknesses because they are not always accurate at all. With eccentric reaming and nail position, you can get cortical irregularities that look abnormal that are right, and in your cases where they look correct when they're reduced and they're actually wrong. So in this case, again, we had to go back and revise the patient that's on the left, the 60-year-old snowmobile accident, because it was malrotated despite how that radiograph looked. So it just speaks to just checking and being sure that that not just your radiographs are right, but that your physical exam is right. And in this case, when we asked the patient afterwards how she felt, she really was sure that her foot rotated outwards, and it was about 15 degrees off, which for us was worth changing.
I think just, can you go back real quick? So I just,
Yeah,
it's just
I have a question too for him, Brett. Okay, go ahead, Brett.
I was just going to say, it just goes to the point about getting the x-rays right. So the rotation is not the same on the right versus the left. The left one, the patella is centered. The right one, it's not. And so like, especially, that's why I like the AP view, like I use it, but that's not what I hang my hat on, because it's so hard to get it exactly right. Like for me personally. So I'm not saying that it wasn't off, but like, just kind of think about that.
You're right. I mean, I didn't believe my own eyes, right? So I looked at that x-ray and said, these cortical thicknesses on this lady are so perfect. It can't be wrong, because these are my x-rays intra-op. This is my lateral of the uninjured and injured side on that patient that was in the snowmobile box. And it's clearly different.
Yeah, it is.
But I didn't believe it. Like I was convinced that I was right by looking at the cortical thicknesses, but I wasn't. And so I didn't even trust my lesser trochanteric view, but I should have. And so it's just a learning point, you can still screw it up even when you're doing everything right. Believe all of it. Believe your x-rays, believe your physical examination, believe the patient, because, all those things together will get you to your spot that you need to be.
Thank you, Matt, very much.
That's a really great case to show it. That's awesome. Great catch.
That was a very good case. Seems like you only do reconstruction nails, but maybe we'll discuss that offline. Okay. Anyway, the Fireside is will be available for those of you who are interested. There will be a recording, link to the recording sent out 24 hours after the conclusion of the webinar. I really appreciate my faculty, Brett and Matt, amazing surgeons and very thoughtful. Thank you all for participating and being here with us. In summary, like I mentioned, trauma patients are highly motivated and expect to be put back together with anatomic alignment, length, coronal, sagittal alignment, and then don't forget rotation. I think rotation is the hidden deformity, and it's hard to get right. I think we had a very good discussion of that today. And as Matt really eloquently described, there's a lot of strategies to get all the components of alignment correct during diaphyseal fixation. And I can learn the last point a lot again, just to remind myself, follow patients post-op for malrotation. We have some very interesting and engaging faculty set up for the next couple weeks, so feel free to come back and join us, and we appreciate your participation again, and thank you guys very much.